We are Team 8, and for our project, we have designed a new and improved method of ACL reconstructive surgeries. Each year, there are more than 100,000 ACL reconstructive surgeries in the US alone, so ACL tears are an extremely common injury. The ACL connects the femur to the tibia and prevents the anterior sliding of the tibia, as well as hyperextension of the knee. The ligament tears most often during physical activity and can occur both in contact and non-contact situations when the tibia rotates while the femur remains in place. Once a tear is suspected, it is confirmed with an MRI and classified as either a grade 1 sprain, where the ligament is stretched but still supportive, a grade 2 tear, where part of the ligament tears, or the most common grade 3, where the entire ligament is torn into 2 pieces. Although the ligament is torn beyond natural repair, in more than 50% of injuries, remnants of the ligament remain attached to the bone. The gold standard surgical options are doing an autograft where the patient's own patellar tendon, hamstring, or quadricep is used, or an allograft where the patient receives a graft from a donor's patellar tendon, hamstring, or Achilles. The autograft procedure requires a second surgical site that leads to increased surgical time, donor site morbidity, and altered site biomechanics, as well as causing increased physical therapy to be necessary and a higher prevalence of re-injury up to almost a quarter of all patients. Using an allograft eliminates the concerns with the second surgical site, but has an increased risk of infection and tissue rejection since the tissue is from a cadaver. Both of these procedures use different kinds of tendon or muscle tissue, which causes the grafts to be very weak in the early stages of recovery, as the new tissue must adapt to different biomechanical requirements they were not originally made for. On top of the physical problems caused by the traditional ACL reconstruction surgery, there's also a large financial burden placed on the patients, with the average patient cost being over $9,000. To combat all of these negative effects of the gold standard ACL reconstructive procedure, we defined our clinical need as designing a new solution to functionally regenerate the ACL that will decrease patient pain and discomfort and quicken and improve the recovery process. To accomplish our clinical goal, we identified 3 main engineering needs. The implant must withstand loads of 2,160 newtons, have a stiffness of 242 newtons per millimeter, and withstand at least 10% strain to ensure that the graft has biomechanical properties similar to the native ACL. We also identified 4 main stakeholders involved in our project. First, the target population, the patients themselves, as well as the orthopedic surgeons performing the procedure, the hospitals and surgical centers where the procedures take place, and the physical therapists who help the patients rehabilitate their injury after the surgery. Our main competitor will be the traditional ACL reconstructive surgery, which we've already talked about along with its many limitations. There are also a few other methods that are currently being used in clinical trial. First is the BEAR method, which stands for Bridge Enhanced ACL Repair. This method involves suturing a collagen scaffold to the torn end of the ligament and suturing it in place through the ligament and also through the bone. It is then secured by a cortical button for extra stabilization. The scaffold is then saturated with the patient's blood to promote healing. The main issue with this is that the patient's tear needs to be in the center of the ligament in order to apply this method, so it has a very specific and small patient audience. Next is the DIS technique, which stands for Dynamic Interligamentary Stabilization. This method involves inserting a spring mechanism into the tibia below the ACL. A braided wire is then passed from the spring through both torn pieces of the ligament and secured to the surface of the femur through a cortical button. While clinical trials have shown better outcomes in healing time, mostly due to the fact that surgery can take place sooner after the injury, it also includes different metal materials that can undergo different forms of corrosion, specifically in the implanted bone device. The final method is the anchor repair method. This method stabilizes the ACL stump in order to drill through the center point and place an anchor in the tibia at the ligament insertion site to the bone. This ligament is then reduced in order to add the graft. While this method does reduce the bony tunnels made in traditional reconstructive surgery, it's still the same issues associated with the autograft and allograft procedures.
In order to meet the clinical and engineering needs, we have developed a novel ACL scaffold that combines several different research techniques in a continuous process. First, we intend to obtain porcine or pig ACL from the stifle joint of the hind legs due to its similarity in physiology to the human knee. The decision to use pig ACL over other large animals was driven by the anatomical and biomechanical similarities, as well as the ease of sourcing. Porcine ACL has the same ligament bundles as the human ACL, which provide both flexion and extension, and is also longer in length than humans. While the porcine ACL mean ultimate load and stiffness values are less than the tensile properties in humans, the ultimate stress is closest to that of humans, suggesting that size correction may change mechanical properties. Once corrected to the length that a patient requires, we expect different values for porcine ACL mechanical properties. In terms of sourcing, pig hind legs can be obtained from an abattoir or slaughterhouse, and the ACL would be removed surgically under sterile conditions in lab. The obtained porcine ACL would first be sterilized using peracetic acid and antibiotics to prevent infections. It would then be decellularized using sodium didecyl sulfate, or SDS, and Triton X detergents through a perfusion bioreactor system. The reasoning for using these specific solutions for decellularization is that they effectively lyse porcine cells and genetic material without negatively affecting the structure of the extracellular matrix, primarily composed of collagen 1, elastin, and related proteins, which we want to maintain. Distilled water washes would be used in between and after the perfusion cycle of the decellularization medias to avoid the accumulation of detergent surfactants on the scaffold. The scaffold would go through a final wash of phosphate buffer solution, in which it can also be stored for later use or transportation because it is sterile. The process would require about 5 to 7 days to get a fully decellularized porcine ACL, and before moving forward, removal of porcine cells would be verified by DAPI or H&E staining assays. A perfusion bioreactor circulates media through a tissue or scaffold via a pump and tubing circuits, carefully modulated and customized through a bioprocess control system. We chose to use a perfusion bioreactor for both decellularization and recellularization because of its advantages in promoting media to reach all parts of the tissue and scaffold and promote cell proliferation through enhanced nutrient transport, mechanical stimulation through stirring, and maintenance of a controlled, sterile, in vivo-like condition. Once the scaffold is decellularized, we will use gamma radiation to further ensure sterilization. Using a dose of 15 kilogray will eliminate all microbes, but using this lower dose limits the amount of mechanical weakening to less than 15%. In order to further protect our implant, we plan to experiment with different kinds of radioprotectant pretreatments, such as free radical scavengers like N-acetyl-L-cysteine. These radioactive treatments prevent the ionization of the surface that cause the collagen crosslinks to disband, decreasing the implant strength. The decellularized scaffolds would then be recellularized with human dermal fibroblasts obtained from the patient themselves through a minimally invasive punch skin biopsy to avoid an adverse immunogenic response. The patient-obtained skin sample would be cultured and processed in a way to only derive fibroblasts and amplify their cell count. The scaffold would be suspended in the perfusion chamber filled with DMEM media and fetal bovine serum to promote growth, Glutamax to provide the cell's nutrition, and streptomycin to prevent contamination. The patient's fibroblasts would then be introduced to the chamber and allowed time to attach to the scaffold before applying a perfusion rate of 5 milliliters per minute. Additionally, perfusion bioreactors result in parallel alignments of cells along the scaffold, which is how fibroblasts are naturally arranged on the ACL. Finally, the prepared scaffold would be implanted into the patient's affected knee using a suture repair technique, where our scaffold would be attached to the native torn ACL pieces using biodegradable sutures that would be fixated using small 4 millimeter bony tunnels secured with an endo button on the femur and tibia. This is to ensure that the scaffold does not move out of place while the ACL heals. Additionally, the suture choice would be such that it does not degrade before a 6-month healing period is over.
There are a number of benefits our solution has over the gold standard. Firstly, there will be very little donor site morbidity with our procedure. A second surgical site is not necessary, which is used for autograft surgery. The only associated morbidity would be from the punch skin biopsy to collect human dermal fibroblasts from the patient. This is an outpatient procedure that is simple and quick, taking only a 3 to 4 millimeter sample, which causes minimal damage, which can be healed in a matter of weeks to 2 months. Additionally, compared to the allograft surgery, our scaffold will have a reduced risk of rejection as we are decellularizing the porcine ACL before implantation and reseating the scaffold with the patient's own fibroblasts in order to avoid an immunogenic response. We chose to use smaller tunnels for a suturing attachment method in order to avoid excessive osteolysis. Also, by avoiding screws as a means of attachment, issues of rejection, screw failure, and corrosion are circumvented. Additionally, pain at the site of screw fixation is present in 25% of ACL patients. The incorporation of smaller bony tunnels and biodegradable sutures rather than screws would enable an easier and less painful recovery for the patient. Furthermore, our scaffold induces growth and wound healing from the native ACL, which is not present in reconstruction surgery because the remnants of the torn ACL is removed before a graft can be implanted. Also, our scaffold will achieve similar mechanical properties to native ACL, as we will be using a decellularized porcine ACL for our scaffold rather than a graft from another tendon, such as the quadriceps or hamstring, which may have different mechanical properties. This table shows the cost for the fabrication of our scaffold. The price listed for each solution is 1,000 milliliters. We estimate that our scaffold will take $1,570 to fabricate, not including the perfusion bioreactor, which would be a one-time purchase for $10,000, and this bioreactor could be used for the production of multiple scaffolds. In comparison, the standard autograft surgery costs just over $4,000, while the standard allograft surgery costs a little over $5,000. Additionally, physical therapy and operating room time are other costs associated with ACL recovery. We expect to cut down surgery time because we will be fabricating our scaffold outside of the operating room, so there's no need for a second invasive procedure like that in an autograft. Additionally, physical therapy costs can be diminished because therapy for donor site morbidity will not be necessary, and we expect a quicker and more efficient recovery for the patient.
So our solution is not without, is not without limitations. We're using dermal fibroblasts and not ligament fibroblasts. Therefore, our scaffold may not have adequate strength, which is something we could test for. So we chose to use dermal fibroblasts in order to avoid another invasive procedure and cut down on costs. Another limitation is that the suture fixation method is only possible with full tears and sufficient tissue quality, which limits our demographic. For partial tears or if tissue quality is not sufficient, our scaffold could still be attached using interference screws like that in reconstructive surgery. So moving on to experimentation, we could use the Instron for mechanical testing. We could test the maximum load, stiffness, and strain according to ASTM standards based on mechanical testing of bioscaffolds. And based on the porcine ACL after recellularization, we would want to meet the engineering criteria previously discussed. For biocompatibility, we would want to test the cell viability within the scaffold at various points. So we could use the live dead assay before and after our trials in animal models to check cell proliferation. The picture on the bottom left shows an example of results of this assay in which the green cells are alive and the red cells are dead. So one limitation is that this test is not cell specific. It would just look at all the cells we tested, even if unwanted cells grew on the scaffold. We'd also need to check the inflammatory response and make sure there's no cytotoxicity according to ISO standards. So in animal models in vivo, we could use an MRI as it's best for evaluating tissue. And while in vitro, we could apply the MTS assay to determine if cells are metabolically active to evaluate cell proliferation as well as cytotoxicity. For our small animal model, we chose a rat, and for the large animal model, we chose a sheep based on previous literature. So we're going to test for biocompatibility, healing, and mechanical functionality using the previously mentioned tests and assays. We would perform a graft harvest to do in vitro testing, but before this, gait analysis can be performed as in vivo testing after the surgery to check for proper mechanical properties in the healed tissue. Thank you for your time.